We are just welcoming folks in, and we'll be starting here in a minute. We have about one more minute as folks are coming into the session. Thank you all so much for joining us this morning. We are going to be recording our event today, and you all should have a prompt that gives us permission to record. Thank you so much for that. We do embed a link in our key learnings document that has a YouTube recording of this event. So thank you for being with us today. My name is Maria Clemesrud. I'm a Senior Improvement Advisor with Comagine Health. This is the first of our new series. If you've registered, you registered to be with us through August, and we are excited that you're here with us. Today's topic is fentanyl in our community, and we are grateful for the panelists that have expertise and have given us their time to share with us today. Next slide. Our peer-to-peer learning series is the fourth Tuesday of each month at 10 a.m. We do a 25 to 30-minute discussion led by Dr. Michael Parchman, and then we do breakout groups and a lightning round reporting out. We hope that you will all stay with us through the breakout groups and the reporting out, because this is where we learn the most from you. So please stay. Our October topic is with the Port Gamble S'Klallam Tribe, their youth opioid prevention program. Please join us for that. And then we will not be meeting in November and December, but again, starting in January. Be watching for a survey that will be coming to you to give us ideas for topics for next year. We value your input and want to know what is happening where you live and the things that are top of mind for you, so that we can inform our calendar for the coming year. Next slide. As I said, we have a panel discussion, breakout groups, and then a large group sharing. Our panelists will also be in the breakout groups, so this gives them an opportunity to get to know you and to hear what's happening in your county. As we start, please put in your name, where you are, and who you work with, who you work for. We'd love to know where you're located, and we have 43 participants now, and there's always a great representation from around the United States. Next slide. We could not do this without the internal Comagine team, so thanks to everyone behind the scenes and in front of the screens for your work and your time. Next slide. I'll hand it over now to Dr. Michael Parchman, who will begin our discussion.
Thanks, Maria, and welcome everybody. So happy you could join us today. I don't think fentanyl needs any background or context. I think all of us who work in the field of substance use disorders are acutely aware of the impact it's had on our communities and on our daily work over the last several years. So I'm going to introduce our panel members and dive into our discussion today. The first person I want to introduce to you is Emily Leipold. Emily is a ARNP with the Evergreen Treatment Center here in Seattle, Washington. Our second panelist, Gwen McKay, is the director of Peer Kent in the city of Kent, Washington. And our third panelist is Everett Maroon. Everett is the executive director of Blue Mountain Heart to Heart here in our fair city of Walla Walla, Washington. So glad that all three of you could join us today. I'm just going to jump right into our conversation. And Emily, I'm going to start with you. Can you tell us a little bit about yourself and the organization where you work, and what are your roles and responsibilities there? And again, thank you for coming.
Absolutely. Thank you for having me. My name is Emily Lippold. I'm a nurse practitioner at Evergreen Treatment Services. A little bit about me is I'm Canadian, and so I went to school to be a nurse practitioner in Canada, and the program that I chose was subsidized by our provincial government, and so they got to dictate what our curriculum was, and they decided that our curriculum was going to be geared towards underserved populations and people of lower socioeconomic status. So that was my background in school as a nurse practitioner. And when I came to Seattle, I opted to start my career at this location called Pioneer Square Clinic, where I started during the pandemic doing outreach to our homeless population to provide primary care. And from there, I found a position at Evergreen Treatment Service that allows me to do outreach as well. So I am going to be the medical lead and nurse supervisor of our new project called Therapy in Motion, where we take a mobile methadone van and go out into the community and provide methadone to people who can't make it to our typical brick and mortar buildings.
I'm excited to hear about that.
Yeah, it just came about in the last few weeks, so I'm pretty jazzed.
Yeah. I remember us talking to you earlier, and you were like wishing for this.
Yeah, I guess spoke it into the universe. And so and so right now in clinic, I do intakes for patients who are interested in methadone. And then from there, I see them to do dose evaluations to get them to a dose that feels comfortable for them. And during that time, I try and employ and try and include our substance use counselors and our peer support as much as we can, because it's very obvious that those are super important for our patients to be able to sustain recovery.
So let me ask you about fentanyl. How is fentanyl affecting the patients or clients that you observe, that you serve, and what do you observe when they enter treatment? How is it different or similar to what you see people who enter treatment that have not been exposed to or consistently using fentanyl? Or what's your observation?
In my experience providing care at Evergreen Treatment Services, I find that the patients who are using fentanyl are using more fentanyl than the patients who would be using heroin. In addition, their withdrawals are more intense and more frequent. And also patients are reporting it's harder and harder to find heroin, and so they have to use fentanyl, and patients are scared of fentanyl, to be honest. A lot of them come in here because they've had somebody who's passed away or has had a very scary event with fentanyl and they want to get better. I also see that our doses for people who are using fentanyl are typically a little bit higher than people who were just using heroin. That's not scientific, that's just what I've been seeing in the clinic.
Sure. So what are you doing differently now than you would, say, a couple of years ago, or when you first started as a nurse practitioner? What are you doing differently now than, say, a year ago because of the phenomenon you just described?
I would say that I try to gather a big network of people to help these folks. Beforehand, I was working in a primary care clinic, and so we didn't have the same resources that we have here. So it's just a little bit of different resources, but I truly find that adding several pieces to their puzzle of recovery is really what is helpful. It's not, medication is just one piece of it, but I would say that the difference between 2 years ago and now would be that we have to provide a lot more support to these folks because they typically do have more challenges staying in the program and with meeting requirements. And just a lot of strength-based motivational interviewing, I think, has been helpful and has probably been really useful in the last 2 years.
Yeah, so you're in a very urban sort of inner city. The clients you serve are sort of very urban inner city clients. So when we last talked, we said, what would you like to do or differently, or what would you like to offer? What would your hope be that you could offer? And you mentioned some sort of mobility. Tell me the background behind that. Why was that important, and how did that come about?
It's important because a lot of people with substance use disorders live their lives in 2 to 4 to 6 hour increments. And a lot of the times the dosing hours at clinics just aren't very reasonable for people that are suffering from these substance use disorders. I mean, our clinic is 5:30 in the morning until 1 in the afternoon, and that's not ideal for people that are going through withdrawals or that have other appointments to do during the day. So the goal is to be able to meet patients where they are and understand that this is a really complicated diagnosis, and we have been doing what seems like the same things for several years. And this is as far as we've gotten. So we need to move forward and find different things that are going to be helpful for these folks, because they deserve the help.
Yeah, great response. I'm just going to turn to the participants and encourage you at this point that if you have questions for any of our panelists, to pop them into the chat, and we'll just keep track of those. If Maria or somebody could help me look in the chat and see if there are any questions as we go along. Emily, thank you. Are there any other observations? Anything else you'd like to add before we move on to the next panelist?
I think just that hopefully with doing the mobile methadone, we can add services onto that, like wound care and foot care to start, and then hopefully go from there to do some primary care, but just making sure that we're meeting the needs of the people that really need help.
Can I ask you one last question? Sorry to kind of impromptu ask you this. You said clients come in and they're afraid of fentanyl. Do you offer fentanyl test strips, or is that something that you'd like to be able to do?
I did have a few in my office that I was offering to patients, and they found that really helpful when they're only trying to use methamphetamines, or if they're only trying to use heroin. But then at the same time, they're like, well, it came back positive, but that's all I had, and I didn't have any more money, so I just used a little bit less. So it's a very scary line of, my withdrawals are really terrible and I feel awful, or I might overdose on this. So usually when I give those test strips, I talk about the importance of harm reduction, of using with a friend, making sure that you have Narcan open on the table near you, those kinds of things.
Is it a door open to talk about methadone and other ways they can get off that horrible treadmill?
Yeah, I mean, it's just so multi-layered and so challenging, especially with fentanyl, because it's kind of getting in everything. They just, and then on top of it, sometimes patients also suffer from a benzodiazepine use disorder. So methadone causes respiratory distress, or respiratory decrease, and so does benzodiazepine. So a lot of the times when we're Narcaning people, I'm wondering, like, they do come back after 4 sometimes, but then you can see the benzodiazepine will hit them, and they'll be yawning and be visually in withdrawal and be feeling like they're in withdrawal, but the benzodiazepine will start taking over and sedating them. So there's a lot of challenges.
Wow, very complex. Well, thank you for what you do.
Thank you.
Really appreciate the fact that there are people like you out there in our community. I'm going to turn to Gwen. Gwen, you work at Peer Kent. Can you tell me about Peer Kent? What is it and what do you do there?
Yeah, so I'm the director of our site. We have 4 sites across the state: Spokane, Olympia, Seattle, and Kent. Kent, we're a bit flexible, and you could think of us more as South King County providers. At our core, we're a peer-based recovery center. So everybody here identifies as somebody with lived experience, whether it's mental health, substance use, behavioral health, chronic illness, or trauma, that we're trying to find ways forward in. So we offer recovery supports, one-on-one peer coaching for whatever your self-identified recovery goal is. We offer group settings if you're looking to help process trauma and grief, if you're looking to identify purpose in your living, if you're new in recovery and you have no idea how to have fun while sober, come and play in our games group. We got it. We also offer employment support and housing support because, again, on that journey of recovery, having housing and employment are critical elements. So we're sort of a conglomerate of all those essential needs services without actually providing the tangible pieces. We'll help direct you to material support in the community, but we're here for the emotions, the healing, and the feelings.
Wow, that's awesome. So who are your peers at Peer Kent?
Yeah, I was
How do
thrilled to see that this was titled as a peer-to-peer
Yeah,
engagement.
yeah, exactly. So in your setting, who are peers and how do you recruit them and train them?
Yeah, so peer for us is anyone who identifies as having lived experience. Again, lived experience, mental health, substance use, behavioral health, chronic illness, trauma. You tell us when that's applicable for you and how we can be able to help you. And so we use the term peer to really reduce that power differential because all of us have that lived experience in our background, and oftentimes it's more present. Mental health doesn't go away because you're doing right things. You might be in remission, you might have good days and bad still ongoing. So we recruit predominantly people who were members first. You come in seeking services, and the idea is that we help you get to a point of stability. You can volunteer, you want to give back. 4 out of our last 5 hires were all front desk volunteers or coaches before they got hired on as peer services specialists. So we're very privileged that our approach works for many, many people. It's not the only approach. It is often done in conjunction with methadone, in conjunction with 12-step, in conjunction with religion. We are here to support you in your identified journey. And so we sort of have feelers out in all the different recovery avenues and communities. As far as training, we do a 40-hour intensive called a Recovery Coach Academy. So every one of our staff ends up going through the Recovery Coach Academy in addition to our coaches. The basic elements are looking at your own stuff, how to suspend that judgment, how to suspend your own emotions when dealing with stuff that's coming up, especially your own traumas, and really focusing on how to support someone else in theirs. A lot of motivational interviewing, mental health first aid, RAP training, and then we encourage all of our staff and a lot of our members to ultimately go through the CPC training, so Certified Peer Counselor training.
Great, thanks for that. Let's turn to the fentanyl crisis in your neck of the woods, which is south of Seattle, south of downtown Seattle. What are you seeing? What are your peers seeing on the ground? And how are you responding to what you're seeing on the ground related to fentanyl use?
Yeah, so I would echo Emily again, a lot of fear around fentanyl. There's been a lot of education, which is amazing, stating the dangers of fentanyl, but knowing that it's scary doesn't necessarily help you stop using. We're seeing it in the meth, in cocaine, in heroin. It's cheap, it's easy to produce, it's accessible. I know we were talking before this about the rainbow fentanyl that's coming out to really try and encroach on sort of the party scene and make it accessible for teens and kids. It looks like Pez candy. I know a few weeks ago, there were 3 pounds of fentanyl seized in a raid north of Seattle, but that's not even a fraction of it. our demographic, again, we meet you where you're at. So when you walk through our door, you likely aren't sober or at your recovery journey's ideal point yet. So we have a lot of the testers who come in with the blues, and we can see what the trends are a little bit ahead of time. So a few months ago, there was a particularly bad batch that came in, and we saw 8 of our members overdose in a week. We were 7 out of 8 survived and were hospitalized, and that was amazing that 7 out of 8 were able to survive. But we see a lot of the very immediate consequences of what's coming into the county. We're also incredibly lucky that public health chose us in Pure Seattle as the sites for Narcan vending machines. So we have free Narcan on site. It's anonymous. You answer 5 demographic questions. If you don't have a phone, you can use our computer. You can use one of our phones. 5 demographic questions, and we can issue you either a nasal Narcan or an IM naloxone once per week, along with a fentanyl test strip, or if you choose a secondary item, it can be condoms, it can be other protective things. And that has been incredibly popular.
How many uses or kits have been distributed through your vending machines?
So we are new. We've only been operational a couple of months now, but we carry, it's about 150 boxes every refill, and we've been refilled 3 times so far.
Oh, so did you say 3 times so far?
In a couple of months, and we carry about 150 boxes just of the nasal Narcan, but then we also have the IM naloxone.
How do you
Public
choose?
health would have the direct numbers for that.
Yeah, how do you choose the locations for the vending machines?
That would have been public health. We were offered to be one of the sites, and immediately said, absolutely, please bring it here.
That's great. So what's next regarding fentanyl in the community you serve? If you could complete the sentence, I wish I had blank, what would you say?
So I took this to our staff meeting, and the answers that I got was, I wish I had more Narcan so I could do outreach. We know where the pockets are of people that are using. If we had the Narcan, we would just drive it down and distribute it. We wish that we had quicker turnarounds for detox and inpatient beds. When someone's ready, it's really tough to say, great, in 3 days, they'll come pick you up here. We wish we had more education around addiction, that use for so many people is just a piece and a short-term part of their lives that are hopefully very long, but that how we treat them and how we support them during that time has lasting impacts. We wish we had more low barrier housing, because it's really tough to go to inpatient, have a transformative experience, and then get released back into the same situation you were in. And then we wish we had more understanding around trauma that leads people to use and stay in those cycles.
Yeah, very insightful comments. I saw a question pop up in the chat. How is the Narcan paid for that goes in the vending machines? Who covers that cost?
So public health is currently funding it. I can give you the contact for who does it. I think they're hoping to expand the project.
So Seattle King County,
Seattle King County Public Health.
Yeah.
Those are test strips, very helpful.
And the test.
And I believe the funding came out of the Blake funding, and it was a subset of those dollars.
Okay. Well, thank you, Gwen, and again, thank you for all that you do. I wish we could clone people like you. We need a lot more of you out there. Anything else you want to add before we move on?
Thank you so much for having us, and I look forward to hearing from everybody else through the series. Thank you.
Well, you're amazing. Thank you so much. Everett, how are you, my friend?
I'm hanging in there. How are you?
Good.
Good to see everyone. Yeah, my name's Everett Maroon. I'm the executive director of Blue Mountain Heart to Heart. We're a 501c3 nonprofit in Walla Walla, Washington. So if you take the state of Washington and you've got Seattle over in one corner, we're pretty much in the other corner. We're about 5 or 6 miles from the Oregon border, and maybe if as the crow flies, we're probably an hour's drive from Idaho, but that's not how the road goes. So it's a couple hours to Idaho. That's the road. Yeah. We do a lot of things at Blue Mountain Heart to Heart around substance use. We have harm reduction programs that include syringe service programs. So we've got 3 fixed site SSPs, one in Kennewick, which is in the Tri-Cities, one in Walla Walla, and one in Clarkston, which is on that Idaho border. We have a mobile SSP that also goes out that we've had, I guess, since 2018 or so. We now have a mobile medical clinic, so that's staffed with 2 nurses, and once a week we have a physician. On that, we've got 2 exam rooms and 1 lavatory on that mobile clinic. I think, Michael, when we talked, I was still in the process of acquiring it. We've now acquired it, so
Congratulations.
we have a naming contest for it too, so we're still trying to figure out what to call it. But on that mobile clinic, we can do vaccinations, wound care, of course, syringe services, naloxone distribution. We're working on doing mobile buprenorphine prescribing. In Kennewick and in Walla Walla, we have low barrier access to Suboxone and buprenorphine. We're working on, we have some funding from HCA to do Sublocade, which is the long-acting buprenorphine. We have the medical contract for the Walla Walla County Jail, and so I'm most interested in trying to use it for folks prior to release into the community, because we know that release from jail is a driver for overdose and overdose death, because you've basically interrupted people's tolerance while they are incarcerated, and then when they go back out into the community and use again, they tend to overdose at that point. So if we can get them with Sublocade, before they're back out, then maybe we can try and find them on the, at our low barrier clinic on the outside once they're out. And then we could continue that Sublocade approach for 1 or 2 more months before we transition them, gesundheit, to Suboxone. So we're doing that. We're also doing hepatitis C treatment with our physician, which I think is great. I would say somewhere around 40% of our people who have been injecting substances have hepatitis C. A lot of them know that they have hepatitis C, but a lot of them don't. So prior to COVID, when we were doing hep C testing, I would probably find 8 to 10 new cases of secondary, or chronic rather, hepatitis C in folks per month. So it's very, very, very infrequent for us to find a new case of HIV, but for hep C, wow, a lot of folks. We also, see a lot of syphilis, and so we're doing syphilis testing on the bus as well. We're seeing a lot of secondary syphilis here, and so we get very concerned when we start to see things like hep C, syphilis, gonorrhea, other STIs, because we know that there could be an HIV wave after that. We are one of the few SSPs in the state handing out safer smoking kits. In Washington state, the law is very unclear about the legality of safer smoking kits, but it is a civil offense in Washington state, $100 per. ACLU of Washington does have a legal defense fund set up, so if anyone does hit me with this, I can turn to them and try to get reimbursement. But we were really seeing such a downward trend of participation at our SSPs because, as everyone else on the panel has pointed out, we just have lost heroin. It's just not here anymore. I did some interviews with folks up in Spokane a couple of weeks ago who use fentanyl, and what they reported was it was like a 1 to 4 month process where heroin was prevalent and then it was just all fentanyl. That to me, something and they could even tag it to COVID. It was March of 2020, couldn't find heroin anymore. So when something happens that fast, policy and protocol is not going to be in step anymore. These large organizations and institutions, we have to scramble to try to stay with what's going on the ground. So our programs are really, what I appreciate about being a smaller nonprofit is, we can kind of try and attempt to stay agile with how things are changing. We were giving out fentanyl test strips for a long time, but they all came back positive. And so everyone just knew it's here. We tell people, please don't use alone, or if you're going to use alone, call a friend before you use so that they know to call you in 15 minutes. And if you don't pick up that phone, then they're going to come and check on you. One of the disastrous things for overdose death in Washington State, which is in the double digits increased over last year, is that we used to have like a 4-hour window with heroin or organic opioids from, unconsciousness to hypoxia and death. But the potency of fentanyl as a synthetic is just so much worse that we see 45-minute windows. We see an hour and a half window.
Wow.
So we just have much less of an opportunity to get the rescue in. I know you asked the other panelists about their naloxone programs. We've been distributing naloxone in Southeast Washington now since December of 2014. Our first year, we distributed like 15. We're up to about 2,385 this year, 2,385 we've distributed. Wow. And we've seen 482 reversals reported from our participants. Last year was an all-year high for us. That was 301. And we're at 482. So just to give everyone some appreciation of how rapidly the ground is falling out from under our clients and participants, that is really, I think 5 years ago, Walla Walla County had maybe 5 or 6 accidental opioid overdose deaths, and we're well over 50 this year.
So Everett, let me just interrupt you and say, what solutions would you like to try if you had the time and the resources?
Well, we've all been talking about mobile, going to where people are. I think that is a really wonderful solution because, if you're out in a place like Pomeroy and you don't have a vehicle of your own, you're relying on someone else, and the people you rely on are people that want you to continue to use substances. You really, you can't access care. I think, a few years ago, we had something like, there were a few studies, I want to say it was Fenway, who did one of them, Fenway Center, that showed like 90% of people using opioids aren't in any kind of treatment program. And we've worked really hard the last 5 years to change that number. And now 87% of people don't have access to or aren't getting treatment. So we've eroded that 3%. That's terrible. I think we have to just try as many different things as we can with folks. I hear our authority at Healthcare Authority, who does OTPs, has said, let's write some new rules in Washington State so that we can have more satellite methadone programs. Maybe my organization is too small, or Walla Walla itself is too small to really go through having its own methadone center, but the methadone clinic in the Tri-Cities could collaborate with another organization that could, take a mobile clinic around to folks that otherwise can't make it in to get their daily dose. All kinds of innovative solutions, I think, should be on the table for discussion now, because, the stakes are just too terrible to not come up with out of the box solutions.
Seems like a break the glass moment.
Yeah.
Wow, that's amazing. Let me just ask the other panelists, do you guys have questions for each other? Emily, Gwen?
I do. Gwen, because I know that Pier Kent there's also Pier Seattle. I guess my question is, how do you guys work within the community other than your specific locations? I know that we have a peer, we have a peer, he's across the hall from me, Michael, he's amazing. And every time my patients leave my office and they are unhoused, I'm always like, why don't we pop by Michael's office and you can just meet face to face and then we can go from there. And they always have really great experiences. But other than your brick and mortar locations and being at Evergreen, I don't really know where else peers are.
Yeah, so thank you again to Evergreen for being an incredible partner. We have 3 peers, positions that are embedded across or at 2 different Evergreen Treatment Service locations. So 2 up in Seattle and then 1 down in Renton. We also have peers in libraries. So we have a peer placement in Bellevue Library, one who splits Renton and Kent, one who is down in Federal Way, and then we're hoping to open a 2023 position in the Burien Library. We also have 3 peers assigned to King County Drug Diversion Court. We also have 3 peers that are embedded in South King County Municipal Courts at this time. So if you are a municipal court in Renton, Des Moines, or Federal Way, we have an office there you can pop in, and perhaps you have a charge for one thing, but substance use might be behind it, or mental health, or family trauma, family disruption. And we can help you navigate through that piece with things that maybe you can't or won't tell your attorney or your public defender or your PO, or things that your family doesn't know you're struggling with. Everything is completely confidential and not actually directly connected to those systems. We operate independently out of those arenas. So we have incredible partners that allow us that flexibility and privacy to maintain those relationships.
I think I heard you, Gwen, say that the peers are embedded in the public libraries and in the municipal courts in South King County. Did I hear that correctly?
Yes.
Okay, thank you. Great. Well, I'm afraid our time for our panel is over. We've got to turn to our small group discussion, but oh my gosh, what a rich conversation this has been. Thank you, Emily. Thank you, Gwen. Thank you, Everett. Really appreciate your comments and your insights today.
Thank you for having me. This was very fun.
Thank you.
Oh, sure. No, thanks for coming. Teresa, are you going to help with the small groups today?
I sure am. So, you there, Mary?
Yes, yeah, Teresa is busily sorting us into groups. We have facilitators and panelists in the small
Please stay on.
groups.
Please don't leave.
Yes,
Please stay on for the
we
small
see you
groups.
dropping off and our hearts are breaking. We want you to stay
Yeah,
with us.
please stay with us.
Because we learn the most from all of you, and you can choose to just listen if you'd like to in the group. So in a moment, you will be whisked away into your breakout room, and then we'll come back for a lightning round report out and some other announcements. So thanks for sticking with us. Thank you so much, Teresa. I am proud to report out, we're going to have a few members report out officially, but we had amazing representation. We had a substance use disorder provider, a health educator, a public health nurse, a ARNP, nurse practitioner, licensed therapist, lots of great representation across the board with how we help each other and help our clients and our patients and our communities. So really, really proud of that representation from group number 1. Would anyone like to go first with sharing out?
Well, you're with group 1. Why don't you start?
All right, Haley, Carissa, go for it.
This is Haley. I'm a health educator in Nebraska, and we spoke about my current things that I'm doing is One Pill Can Kill through the DEA. We're going to get that to all of the schools in our area. We're doing Narcan and sexually transmitted infections to hang up in the bathrooms in all of the bars in our area.
Thank you so much,
Wow.
Haley. Carissa, did you want to say something about what you're seeing in Clallam County?
Sure, yeah. So I spoke a little bit about how we are noticing an increase in xylazine in the UAs, the tox screens for folks who are in treatment programs, which has been just kind of a scary trend that is really disheartening. I mentioned, and a couple other people in our breakout group mentioned, that we've just recently, like within the last few weeks or months, learned about xylazine, and seeing that become, a part of the drug supply. It just feels like foreshadowing of what happened when fentanyl started becoming a more prominent part of the drug supply. And here we are kind of scrambling to figure out how to respond to something like that.
Carissa, for those who don't know what that is, can you tell people what that is?
Yeah, So it's an animal anesthetic that is being cut with fentanyl, and it has a synergistic effect with opioids. So Narcan, it doesn't respond to Narcan, but you still want people to use Narcan because if there's opioids on board, it might at least help help revive somebody. But often folks who are overdosing with xylazine on board also are going to need some medical intervention like oxygen or intubation. So yes, tranks. Thank you. That is a more common terminology for it. Thanks, Gwen.
Thanks.
Other groups that would like to share what you talked about?
So Maria, I can present for our group. We talked a little bit about the fact that sometimes our laws in our states prevent us from what's doing best for this type of patient, specifically laws surrounding fentanyl test strips, and the fact that in many states they are illegal, and there are laws surrounding their distribution, and how states are working around that, and individuals are working around that to get the products to patients that need them. The discussion really surrounded the fact that all of the individuals in our group are seeing this increase, this uptake in fentanyl, and the processes that they're putting in place, including mobile clinics that they're working on, and getting Narcan out there in lock boxes for the public to be able to use.
Thank you.
Anybody in our group want to go next? Group 3? What are we talking about?
Jane's got us. Come on, Jane.
Jane, come on, Jane.
So we talked about how fentanyl was affecting all of our states and all of our work, and how it made sometimes buprenorphine maybe not as effective and made it more difficult sometimes for patients to transition from fentanyl to bupe. I talked about what the last speaker, the last reporter said about legislation and how that can really hold us back, and trying to find a strategy that's appropriate when you're a state agency as far as legislation is super challenging. Anything else? What did you, Hannah, you had some good points as well. I don't want to miss anything.
All my points were just, I mean, my previous experience working in a buprenorphine clinic back kind of before, no, it was actually right when COVID was hitting. The shift, a lot of my clients were primarily using heroin and methamphetamine together. But then some folks were telling me they thought fentanyl might be getting mixed in. And then the shift switched to they're primarily seeking fentanyl. Heroin's kind of taken the back seat to fentanyls as the primary drug of choice, which poses a lot of challenges just for buprenorphine prescribing and trying to determine if methadone might be more appropriate for clients. So it's really just posed a lot of challenges.
Hannah, you mentioned that there was a site in Tacoma that was doing buprenorphine, and if a patient wasn't responding well enough to buprenorphine, they were right next door to the methadone clinic, and they could refer them over to the methadone clinic.
Yeah, that's really super lucky, I would say.
Yeah.
It's very fortunate to be able to have that working relationship with a methadone clinic, to be able to say, hey, we have a client who's not quite having good retention rates with their buprenorphine. Maybe it's not making them feel very well. Let's try methadone. Let's get them an induction over there. And it's usually the same day. You can just walk them right over, do a warm handoff, that kind of care. But I do realize that that is not the case in most of the locations. And we, in our group, we also spoke about how rural counties or across the state are just, or in states as well, how there's just lack of resources for people.
Correct. Yeah.
Thank you.
I like Everett's comment about the importance of building trust in the communities they work with, and they really focus on building trust as a key component of success. So thank you, Everett.
That's wonderful. We have just another minute. Do we have another group that would like to report out?
Yeah, I can report out, Maria.
Oh,
Some things
wonderful.
we talked about, and our group was talking, again, some of the challenges that other groups have mentioned, just echoing that Narcan distribution challenges are very real in a lot of areas. And we wanted to also highlight the importance of peer-to-peer networks, as Gwen talked about in their presentation or on the panel, talking about how it is helpful in overcoming stigma, and stigma just in general in the work that our group was talking about is very real. And one thing I found that was particularly cool, a cool intervention that they were doing that Shelley mentioned was putting flyers and educational materials and stickers in kind of in some interesting places. Specifically, they're seeing a lot of restaurant workers kind of being involved in opioids, and so getting materials to them, and also driver's license renewals. So I thought that was really interesting.
Yes, any out of the box thinking is needed. That's wonderful. Well, thank you all so much. We are going to launch a live poll. We rely on your feedback to make our sessions more effective. So we'd just like you to take a minute to answer these 2 questions, and we will share the results of that poll. I also want to remind everyone that we will be back next month on October 25th, and our theme will be Tribal Opioid Prevention Program. We will have 3 panelists from Port Gamble Slalom Tribe talking about how they serve their members, and we hope that you will join us for that. And then we will be on a break November, December, coming back in January. You can expect a survey from us to inform our scheduling and our topics for the next year. We do rely on you to let us know what's most important in your work, where you have challenges and gaps, and how we can help choose panelists that can bring those topics into the light and share resources. And we also want to remind you that if you would like to share Regina Neal's email with any of your colleagues or friends that would like to register, she can send the registration link to you directly, and that will send you reminders. You'll get the key learnings that has the embedded YouTube link to the series recording, and you'll just be a part of our group for the coming year. So please remember to do that and share that the series with others. And there's the result of the poll. Wonderful. Thank you so much for sharing that, completing that, taking the time to do that. And we are right at the top of the hour, and we will be excited to see you in October. Take care, everyone, and thanks especially to our panelists for being with us today.
Thank you. Take care.
Bye. Take care.